Good evening, everyone. And today we are going to talk about metabolic acidosis. It's a general topic. It is not just particularly pediatrics or adults or newborn. I have brought some from different aspects, both adults, children, and also newborn. So it may not be exhaustive in the sense, but we will touch upon most important points. And also, this is a very dry subject, as you all know, but I want to make it as palatable as possible. Metabolic acidosis is a condition characterized by primary decrease in serum bicarbonate concentration. It leads to decrease in blood pH. That's called acidosis. It occurs either because of too much acid, loses too much bicarbonate, or could not able to excrete the acid. So normally the body maintains a pH between 7.35 to 7.45 through different buffering systems, respiratory compensation, and also renal regulations. These three things involved in maintaining the pH between 7.35 to 7.45. So metabolic acidosis, this seminar is just on metabolic acidosis. We are not going to touch upon respiratory acidosis. We will do it in another session. In metabolic acidosis occurs when there is increase in acid production that happens because of the accumulation of lactic acid or ketones, or because of the loss of bicarbonate that happens either because of diarrhea or renal tubular acidosis, or the kidney fail to excrete, as it happens in renal failure. Metabolic acidosis is divided into two big groups based on anion gap. That really kind of helps us to put them in a different category to identify what could be the cause so that we can treat appropriately. One is called high anion gap metabolic acidosis. And another one is normal anion gap metabolic acidosis. Anion gap, high anion gap is 8 to 12, and normal anion gap when it falls below between 8 to 12. It's caused by accumulation of unmeasured anions, lactate, ketones, or toxins. The common causes are lactic acidosis, resulting from shock, hypoxia, sepsis, diabetic ketoacidosis as a result of insulin deficiency and hyperglycemia, toxic ingestions like methanol, ethylene glycol, salicylic. In those three toxins, the accumulation of formic acid, oxalic acid, and salicylic acid. Renal failure, failure to excrete the acid that happens in that results in uremic acidosis, where phosphate and sulfate accumulation happens. And next group is normal anion gap metabolic acidosis. Anion gap is 8 to 12. It's caused by bicarbonate loss or impaired renal excretion. The gold mark is a mnemonic for the high anion gap metabolic acidosis. You might have heard mud piles. I really like the gold mark, so I put it up here. The G stands for glycols. It is because of ethylene, propylene, this kind of ingestion or infusion of these various toxic materials. They produce glycols that causes high anion gap metabolic acidosis. 5-oxoproline, that's also called pyroglutamic acid. And lactic acidosis, again, two groups, L-lactic acidosis and D-lactic acidosis. We'll go in detail. And methanol, aspirin, renal failure, and ketoacidosis, as it happened in diabetic ketoacidosis. As you can see, L-lactic acidosis further divided into type A and type B. Ketoacidosis could be diabetic or alcoholic or congenital enzymatic defects. And toxins, salicylate, chronic acetaminophen 5 ingestion, which result in 5-oxoproline, and compounds metabolized to or strong organic acid, methanol, ethylene glycol, diethylene glycol, propylene glycol, and toluene ingestions. And finally, D-lactic acidosis. So what is lactic acidosis? This is the most common cause of acidosis in hospitalized patients. It occurs when the lactic acid production exceeds lactic acid clearance. The lactic production increases because of impaired tissue oxygenation. Either it happens because of decreased oxygen delivery or defect in mitochondrial oxygen utilization. Lactate is primarily derived from glucose metabolism via glycolytic pathway. The small amount can come from deamination of alanine. Liver, kidneys, and heart are the major lactate producing organs or utilizing organs. Lactic acid from anaerobic glycolysis and conversion of this lactic acid back to glucose by the liver defines the Cori cycle. So type A lactic acidosis where there is an impairment in tissue oxygenation. In type B, there is no impairment of oxygenation. So when there is an impairment of tissue oxygenation, it results in type A. When there is no impairment of oxygenation, it causes type B. So what are the causes of type A lactic acidosis? You see in hypovolemia, sepsis, major GA hemorrhage, cardiac failure, cardiopulmonary arrest. In this particular acidosis, unless tissue perfusion is promptly restored, the prognosis is poor. Causes of type B lactic acidosis, as we mentioned earlier, there is no impairment of oxygenation or oxygen delivery to the tissues, but it happens in toxins, drugs, vitamin deficiency such as thiamine deficiency. In these conditions, there is impaired cellular and mitochondrial metabolism generate regional areas of ischemia seen in metformin toxicity and other causes like malignancies, leukemia, lymphoma, severe alcohol use disorder, and some antiretroviral medications. All these can cause type B lactic acidosis. Another concept to remember when you are dealing with the, especially the toxin-related acidosis, osmolar gap. Addition of alcohol, acetone, glycerol raise the measured osmolarity and create osmolar gap. What is osmolar gap? What is the measured osmolar and calculated osmolar? The difference is called osmolar gap. It disappears when the alcohol glycol is metabolized to an acid. Most of the time when they take the toxic alcohol, it causes osmolar gap initially. Then once it's metabolized and form an acid, it creates high anion gap metabolic acidosis, otherwise called HAGMA. The patient with DKA also can develop osmolar gap because of acetone, because acetone is not an acid, but it causes the difference between measured and calculated osmolarity. Osmolar gap occurs in alcoholic ketoacidosis, alcohol toxicity, and glycol poisoning. The formula to create osmolar gap is measured osmolarity minus calculated osmolarity. So how do you calculate the osmolarity? By this formula, 2 times sodium plus glucose over 18 and BUN over 2.8. Even though these are all theoretical importance, most of the time what happens when the patient comes in, we automatically check alcohol, aspirin, and all those stuff. So we measure those most commonly ingested agents in the emergency room itself. In rare occasions, when you don't do routinely in those patients, this osmolar gap, especially early on, definitely help in making the diagnosis. Alcohol toxicity. It is the most common toxicity seen in emergency room. The oxidation of ethanol generates acetyl-CoA that is metabolized by the liver. So the ethanol level fall, the accelerated oxidation of co-ingested toxic chemical generate toxic organic acid. Oftentimes, alcohol is co-ingested with other toxic materials. They create organic acid that leads to HAGMA, high anion gap metabolic acidosis. One has to remember isopropanol or acetone is not an acid, so they will raise the osmolar gap but not generate HAGMA. So not all alcohols will cause high anion gap metabolic acidosis, but some will cause osmolar gap. So knowing osmolar gap is very important, especially in those places where the the levels are not done promptly. Other common occurrence is salicylate toxicity. It is the most characteristic acid-base disorder of salicylate toxicity is mixed HAGMA, mixed high anion gap, metabolic acidosis, and respiratory alkalosis. Toxic salicylate levels stimulates the medullary respiratory center that increase both rate and depth of respiration. It causes respiratory alkalosis. Salicylate toxicity uncouples oxidative phosphorylation, inhibits citric acid dehydrogenase, accelerates glycolysis, generates lactic acid, and stimulates lipolysis and hepatic ketogenesis that generates HAG, high anion gap metabolic acidosis. How do you treat? Intravenous saline and potassium chloride. Alkaline diuresis enhance renal salicylate excretion. Most of the time, we give 1.5 maintenance with high sodium. Sometimes we give sodium bicarbonate drip along with 1.5 maintenance and make sure the urine pH remains alkalic. The other group is called chronic ingestion of acetaminophen, especially in malnourished females that can cause high anion gap metabolic acidosis. As you all know, acetaminophen or otherwise paracetamol, that is the glutathione in the liver is important in detoxifying the acetaminophen metabolites. So in malnourished women who are chronically ingested acetaminophen, they run out of glutathione real fast. As a result, they will have accumulation of 5-oxoproline, also called pyroglutamic acid, that causes high anion gap metabolic acidosis. When there is a glutathione or cysteine deficiency, accelerates the generation of accumulation of 5-oxoproline. The HAGMA due to acetaminophen related 5-oxoproline accumulation typically resolves quickly once the acetaminophen is discontinued. Sometimes people use NAC, which is N-acetylcysteine, which is a treatment for acetaminophen poisoning, but according to others, it's not necessary. But the NAC is so not harmful, we tend to do the whole course of NAC, which is about 18 hours. When you do an IV, if you do a oral, it will take a couple of days. Other rare disorders that can cause increased 5-oxoproline or inherited disorders of 5-oxoprolinase or glutathione synthetase. Sometimes certain antibiotics like flucloxacillin and netilmicin can cause and pyroglutamic acid accumulation, and also anticonversions such as vigabatrin, which is most commonly used. So you have to, when they develop high anion gap metabolic acidosis, one has to think that could be the reason from the accumulation of 5-oxoproline. The other one is called D-lactic acidosis, often not discussed that much, like L-lactic acidosis. L-lactic acidosis, especially with less perfusion, most commonly encountered in hospital setting. In D-lactic acidosis, a rare form of metabolic acidosis seen in patients with short bowel syndrome, GA malabsorption. Intestinal bacteria metabolize unabsorbed glucose and form D-lactic acid in the gut. Since they have a short bowel and GA malabsorption, they get absorbed into the blood, causing D-lactic acidosis. D-lactic acidosis, metabolic product of lactaldehyde with propylene glycol intoxication and methyl glycoxyl in DKA. So in DKA also you will see a D-lactic acid. It may reach 8 to 10 milliequivalent, thus it contribute to HAGMA, high anion gap metabolic acidosis. But most of the time, DKA, we focus on ketoacidosis rather than lactic acidosis, very rare. And also, it gets washed out because most of the DKA will have osmotic diuresis. So even though theoretically it's possible it can cause high anion gap metabolic acidosis because of the lactic acid accumulation, most of the time the focus is hyperglycemia and ketoacidosis. But when the patients with short bowel syndrome and GA malabsorption, when they present like confusion, cerebellar ataxia, slurred speech, incontinence, nystagmus, one should think in terms of D-lactic acidosis. How do you treat? Severe metabolic acidosis, of course, when you use buffers such as IV sodium bicarbonate, short bowel syndrome, or antimicrobial agents to get rid of the bacteria that ferments glucose into D-lactic acid. How to prevent low carbohydrate diet and frequent episodes of D-lactic acidosis that happens, and one can use fecal transplantation. What is non-anion gap acidosis? When the anion gap between 8 to 12, but the bicarbonate is low. Either it happens because of accumulation of hydrochloric acid or loss of sodium bicarbonate or sodium organic acid anion salts such as sodium butyrate, citrate, acetate, lactate. It results in hyperchloremic acidosis. Non-anion gap acidosis invariably causes hyperchloremic acidosis. The common causes are GI bicarbonate loss. The second is renal tubular acidosis. There are three kinds. Type 1, which is distal renal tubular acidosis, where there is a impaired distal acid secretions. Type 2, proximal renal tubular acidosis. There is the impaired proximal bicarbonate reabsorption. Most of the bicarbonate reabsorption, I think 85%, happens in the proximal convoluted tubule. When there is an impairment, you will have bicarbonate loss, thus non-anion gap acidosis. Distal one, 15% bicarbonate can be lost from there, but most important reason they develop acidosis because the hydrogen ion secretion happens in the distal convoluted tubules. Type 4 is different, so hyperkalemic. Both type 1 and type 2 causes hypokalemic acidosis. Type 4 causes hyperkalemic renal tubular acidosis. Is it because aldosterone deficiency or resistance? Drugs such as acetosalamide, ammonium chloride can cause non-anion gap acidosis because of the chloride or acid excretion. So when the patient presents with metabolic acidosis with normal anion gap and positive urinary anion gap, if you can measure it, if you have mechanism to do it, not lots of institutions have it. So these first two anion gap automatically comes out of the metabolic panel. So urine pH, serum potassium, and bicarbonate determination. That groups into three. When the urine pH is less than 5.5, low potassium, bicarbonate is supposed to be less than 15%. And other signs of proximal tubular dysfunction, then it is type 2 renal tubular acidosis or Fanconi syndrome. When the urinary pH is high, that's very important. When there is an acidosis, the urinary pH is high. So when there is an acidosis, it's normal, the urinary pH is less because acid excretion happens. On the other hand, if the pH is high, low potassium and bicarbonate is affecting excretion. So bicarbonate is low, it's most commonly dealing with type 1 renal tubular acidosis. When the urinary pH is less than 5.5, high potassium and bicarbonate excretion is less than 15%, then type 4 renal tubular acidosis. These are all kind of difficult unless otherwise you are an advanced center. It's kind of hard to do the bicarbonate excretion, and but on the other hand, you can kind of go with the bicarbonate estimation presence of acidosis. That's good enough. Treatment interfering with the renin-angiotensin syndrome, although still renin levels in obstructive uropathy is commonly will see type 4 in obstructive uropathy. So what are the things you do to make the diagnosis? One, you need to have a blood gas, or even chemical profile will give. Well, blood gas is necessary to determine the pH. So less than 7.35 is called acidosis. The bicarbonate depends on the labs. It says less than 22 milliequivalents. So most of the time you will wait till 16, 18, or 15. Serum electrolytes, but theoretically less than 22 is called bicarbonate, low bicarbonate. Serum electrolytes, calculate anion gap. Anion gap is equal to sodium minus chloride plus bicarbonate together. But most of the time, our the chemical profile will read anion gap. Normal anion gap, as you know, 8 to 12 milliequivalents per liter. Additional test, one should check glucose that will identify diabetic ketoacidosis, ketones, DKA, and starvation ketoacidosis, lactate, salivated lactic acidosis, renal function test to check for renal failure, toxicology screen for suspected ingestions. When you have an acidosis, there are two kinds of compensation happens. One is respiratory compensations by eliminating carbon dioxide, and second is renal elimination. The respiratory compensation happens promptly. It happens within an hour, and it max is within 24 hours. The hyperventilation is reduced carbon dioxide, which is partial pressure carbon dioxide. The expected PaCO2 to change for bicarbonate is equal to 1.5 times bicarbonate plus 8 plus or minus 2. That's Winter's formula. Renal compensation takes days. It's because of increased excretion of bicarbonate reabsorption. So only in chronic acidosis, renal compensation plays a practical role, but respiratory compensation happens right away. What are the metabolic effects of metabolic acidosis? Number one, it causes hyperkalemia. The acidosis causes movement of hydrogen ion cells into the cells and potassium extrudes out. As a result, serum potassium levels go high. It can result in cardiac arrhythmias and muscle weakness. The second one is hypocalcemia. Acidosis increases ionization of calcium, reducing the total serum calcium levels. It can lead to neuromuscular irritability, tetany, or seizures. Third, hypophosphatemia, especially in chronic acidosis, phosphate from the bone moves out to buffer the acidosis. As a result, they can develop muscle weakness and osteomalacia and osteoporosis. Acidosis also increases insulin resistance, impairs insulin signaling, and reduces the glucose uptake by cells. It exacerbates hyperglycemia, especially in children, especially in patients with DKA, and can worsen metabolic control. The correcting acidosis is paramount in switching DKA into just to diabetes. It also what acts on the protein metabolism by increasing protein catabolism and also reduce the protein synthesis. It stimulates the breakdown of muscle proteins to release amino acids, thus leads to muscle wasting and negative nitrogen balance. It also inhibits the synthesis of new proteins, again contributing to muscle loss, impaired tissue repair. So bringing back the pH to normal is paramount. Bone metabolism, as we discussed before, chronic metabolic acidosis leads to release of calcium phosphate from the bones as a buffering mechanism. Over time, it can cause osteoporosis and osteomalacia, especially in renal tubular acidosis present as rickets or fractures, more common because of this particular mechanism. Reduced bone formation inhibits osteoblast activity, further contributing to bone loss. In carbohydrate metabolism, impaired glucose utilization because it reduces the activity of key enzymes involved in glycolysis and glucose metabolism, leading to energy production. And increased gluconeogenesis, so the increased glucose production in response to acidosis, it can worsen hyperglycemia in diabetic patients. It also increases the lipolysis. As a result, it increases the elevated free fatty acids in the blood. It can worsen the ketone body formation in DKA. It also augments the ketone body production, thus further lower the blood pH. So the acidosis per se, even without insulin deficiency, can worsen ketone body formation, worsen acidosis, worsen hyperglycemia. It also impairs ATP production. ATP production, as you know, it's very important for the cell functions. It disrupts the mitochondrial function and the oxidative phosphorylation. It increases the accumulation of lactic acid. These are all just acidosis per se. It increases the cortisol and catecholamines because it triggers a stress response. It leads to the elevated cortisol and catecholamine that worsens insulin resistance and hyperglycemia, reduce the growth hormone and IGF-1, thus impairing growth and tissue repair. So normal metabolic milieu is important for normal healing process. It also increases ammonia excretion. It is so protective in nature. When you have an acidosis, you want to get rid of excessive acid. And also it causes bicarbonate loss, again, that in some form of renal acidosis, it perpetuates, um, perpetuates acidosis. It also causes enzyme inhibition. Many enzymes are pH sensitive. Acidosis can impair function, disrupt the metabolic pathways, and alter cellular signaling. In chronic kidney disease, not addressing acidosis accelerates the progression of chronic kidney disease. It's really important to control acidosis even in chronic kidney disease. And also it causes muscle wasting, leads to sustained protein catabolism, contributing to sarcopenia, which is muscle loss. These are the metabolic effects of the metabolic acidosis. Now we are going to look at the clinical effects, and finally we will touch upon how to treat and inborn errors of metabolism. As you know, it stimulates rapid breathing to compensate by exhaling carbon dioxide. As we said, the respiratory compensation happens right away. It can result in small breathing. It can cause shortness of breath. Cardiovascular effects are very important, especially in patients with hypoperfusion states. When you have a severe acidosis because of hypoperfusion for different reasons, it can be preload or a contractility issue or afterload issues. What does it do? It decreases the cardiac contractility, impairs the heart's ability to contract, thus reduce the cardiac output. Especially when you go below 7, it definitely affects the cardiac contractility. It can also cause arrhythmias, acidosis per se, and also because of hyperkalemia that promotes potassium extrusion from the cell, from intracellular to extracellular, that along with acidosis can cause arrhythmias. In addition, it can cause vasodilation and decrease vascular resistance, result to low blood pressure. So cardiovascular effects are paramount in acidosis. So fixing acidosis is very important to improve the cardiac output, reducing the chances of arrhythmias, and of course, taking care of blood pressure. Neurologically, it can depress the central nervous system, leading to altered mental status. In severe cases, it can cause coma. Due to cerebral vasodilation, it can cause headache. Probably these are the earliest symptoms before altered mental status and coma. Metabolic and electrolyte disturbances, as we mentioned earlier, it causes hyperkalemia, it causes insulin resistance, and bone demineralization because the phosphate buffer move from the bone, causes osteomalacia and osteoporosis. GI side effects, it will become very often seen in patients with acute as well as in chronic acidosis. These are common symptoms of acidosis in the gastrointestinal system. Patients may present with abdominal pain, either because that you see in lactic acidosis and ketoacidosis. Acidosis impairs kidney function, exacerbating accumulation of acids. It promotes ammonium excretion, as we explained before. It is a protective, get rid of acid from the body. Musculoskeletal effects, very important, can cause muscle weakness, especially in presence of hyperkalemia, and hyperkalemia can cause, so not only, it will also impair the respiratory functions, which is the main way of compensating for acidosis. Fatigue, generalized weakness and fatigues are common, especially with chronic metabolic acidosis. So it can cause shock. Acidosis can contribute to circulatory collapse because of vasodilation, decreased contractility, and low cardiac output. It can cause multi-organ failure. As we mentioned earlier, there are two compensation, respiratory compensation that happens immediately by blowing out carbon dioxide. Renal compensation, it happens later by excretion of hydrogen ions and the reabsorption of bicarbonate. Now, how do you treat? There are three goals when you treat metabolic acidosis. One, correct the underlying cause of acidosis. Sorry. Correct the underlying cause of acidosis. Restore normal pH and bicarbonate levels and manage complications like electrolyte imbalances and organ dysfunctions. The three things needs to be addressed as we go. When you're addressing, you need to assess the severity of the acidosis by checking the blood pH, serum bicarbonate levels, and the anion gap. That shifts whether the patient has a high anion gap acidosis or normal anion gap acidosis. And identify the cause. As we mentioned earlier, differentiate anion gap versus high anion gap versus normal anion gap. Then monitor vitals, electrolytes, and organ function because acidosis can, per se, can affect all those three. In addition, even the like shock states, sepsis can also affect vital signs, electrolytes, and organ dysfunction. Lactic acidosis, treat the underlying cause. Sepsis, shock, and hypoxia. It's very important, especially in type A lactic acidosis. Perfusions needs to be remedied right away. Improve tissue perfusion with fluids, vasopressors, or inotropes. Consider bicarbonate therapy if the pH is less than 7.1 and hemodynamically stable. The practically, I like to treat even when the pH is less than 7.2 because the issue of waiting till the end, it takes time to get the bicarbonate. By the time you come and get it and give, it takes time. So I usually preemptively treat when the pH falls below even into 7.2s. If it is a pure metabolic acidosis associated with perfusion, you need to do simultaneously. You correct the acidosis and addressing the fluids, vasopressors, and of course antibiotics and giving oxygen, so on and so forth. In diabetic ketoacidosis, it's different. Bicarbonate therapy is rarely needed. Consider only if the pH is less than 6.9 and hemodynamically stable. In pediatric diabetic ketoacidosis, we do not use bicarbonate therapy. Number one, it doesn't help. It is associated with bad outcome and potentially it can cause CNS acidosis. The treatment in diabetic ketosis is insulin therapy, fluid resuscitation, and electrolyte replacement. Please look at the adult DKA is different from pediatric DKA because cerebral edema is more common and most common cause of death and also resulting lots of neurological morbidity in pediatrics. Please watch my DKA in children in our YouTube channel. Otherwise, the insulin needs to be addressed, fluid resuscitation, electrolyte replacement, and bicarbonate therapy. As I said, pediatric DKA, no. Adult, if the pH is less than 6.9. Toxic injections, methanol and ethylene glycol. These patients, number one, identification is very important. As soon as you identify, but initially they will have osmolar gap and subsequently they develop high anion gap metabolic acidosis. They need to be treated with famiprazole if it is available, 15 milligram per kilogram bolus followed by 10 milligram per kg every 12 hours. If the methanol or ethylene glycol level are high or they have a severe or unresponsive to famiprazole, I'll proceed on to hemodialysis. In some centers, they use ethanol because it competes with alcohol dehydrogenase. The issue with ethanol is it causes obtundation of mentation, kind of hard to see altermentations come from toxicity or because of your treatment. Salicylate poisoning, most of the poisoning can be managed well with IV sodium bicarbonate, alkalinize the urine, and increase diuresis. Some patients will end up in hemodialysis. Again, you need to identify early, and if the salicylate level is too high, or if the bicarbonate or alkalinizing urine doesn't help, then move on to hemodialysis. Renal failure patients hemodialysis because the issue is non-excretion of acid. So the only way to get rid of the acid is by doing hemodialysis. Based on the hemodynamics, you can do either continuous hemodialysis versus intermittent hemodialysis. That hemodynamics and underlying disease will dictate what to do. Bicarbonate therapy may be used temporarily in patients, in non-dialysis patients. Otherwise, the go-to is hemodialysis in patients with renal failure. Normal anion gap acidosis. Gastrointestinal bicarbonates treat with fluid, electrolyte replacement, administered bicarbonate if necessary. Most of the time, fluid and electrolyte replacements will do. Renal tubular acidosis, we mentioned earlier, there are three kinds. Type 1, distal renal tubular acidosis, that's the most common one. Type 2, proximal renal tubular acidosis. Type 4, hyperkalemic renal tubular acidosis. These are all caused chronic acidosis. So the distal RTA treated with oral alkali therapy, sodium bicarbonate or sodium citrate. Proximal RTA treat with high dose bicarbonate because there is a profound bicarbonate loss in proximal RTA and address the underlying cause. If there is a drug causing proximal RTA, avoid those. And hyperkalemic RTA, correct hyperkalemia, that is very important. Low potassium diet, diuretics, and fluorocortisone. So when to give bicarbonate therapy? Severe acidosis with hemodynamic instability across the board. Specific conditions, salicylate toxicity and renal tubular acidosis is very important. Even though, let's say the patient comes with a sepsis with the lactic acidosis, I'll give a fluid resuscitation, vasopressors, improve the hemodynamics, and bicarbonate. Even the vasopressors will not work well in present severe acidosis. I tend to give bicarbonate to keep the pH better so that hemodynamic stability can be ensured with the fluid and the vasopressors. In salicylate and renal tubular acidosis, you go ahead and start with the bicarbonate preemptively. Salicylate, we start with the bicarbonate drip with 1.5 maintenance to make sure urine pH become alkalotic, usually between 8 to 9. Renal tubular acidosis is oftentimes chronic, so bicarbonate therapy, oral bicarbonate therapy is given and sent home on. One exception is DKA. DKA, we will not give bicarbonate because it is associated with the bad outcomes. There are controversies with bicarbonate therapy because it can worsen intracellular acidosis and hypercapnia. When you give bicarbonate, which is CO3, it joins with water causing carbonic oxide, H2CO3, further dissociated to H2O and CO2. That increases hypercapnia, especially in intubated patients. So you have to weigh the pros and cons when you do the bicarbonate therapy. The way I do is give bicarbonate therapy and increases respiratory rate or increase the tidal volume as long as the peak pressure doesn't go more than 35. And use cautiously and only in specific scenarios. You have to keep in mind it can worsen the calcium and worsen the potassium. So you have to kind of keep what impact it will have on the electrolytes when you give bicarbonate therapy. The dosage is 1 to 2 milliequivalent per kilogram IV and monitor the blood gas. So anything you do, follow up with the blood gas and make sure we are not overshooting. Fluid resuscitation is very important since we said lactic acidosis is most common cause of high anion gap metabolic acidosis. The way you treat is isotonic saline or balanced crystalloids. Potassium replacement, especially in patients with distal renal tubular acidosis or potassium deficits associated with acidosis. But most often, acidosis causes hyperkalemia. So you need to balance it out especially DKA. So since we give insulin and glucose, it is going to lower potassium, even though they are normal or a little higher, high potassium at presentation. So you monitor them, very important when you start with glucose and insulin. Calcium and magnesium replace if deficient. So it's not routinely we replace. We monitor them. If it is low, then replace it. Mechanical ventilation may be needed. If it is a pure metabolic acidosis, they will not need mechanical ventilation. But if it is severe acidosis, oftentimes associated with other underlying, for example, sepsis shock, that can cause lethargy, comatose. Those patients need to be intubated and do mechanical ventilation if it is severe enough, or otherwise non-invasive ventilation. When you do that, to avoid overventilation, because excessive carbon dioxide removal can worsen alkalosis during recovery. So when to dialyze acidosis? When there is a severe acidosis refractory to medical management, toxic ingestions, especially methanol and ethylene glycol, if the levels are high, start dialysis right away because stakes are high. It can cause permanent injury, neurological, ophthalmological. Renal failure with acidosis hyperkalemia, it goes without saying there is only way to get rid of the acids by doing dialysis. The chronic management, usually you see in chronic kidney disease and renal tubular acidosis, use oral sodium bicarbonate or citrate to maintain normal pH. Dietary modification also needs to be done to reduce the acid-producing foods such as animal proteins and increase alkali-rich foods such as fruits and vegetables. Monitor electrolytes, renal functions, and bone health periodically. Finally, we will talk about inborn errors of metabolism. These patients can present like metabolic acidosis. I'm going to talk about how to approach, how to treat in 3-4 slides. When the patient presents with the metabolic acidosis, when the pH is less than 7.3, PCO2 less than 30, bicarb less than 50, look at the anion gap. Whether the anion gap is normal, it's most likely we are dealing with either renal loss, RTA, or GA loss. If there is a high anion gap acidosis, again, check the lactate level. Whether the lactate is high, we are going to talk about in the next slide. If the lactate is normal, high anion gap, do ketones and ammonia levels. If the ketose is negative, high anion gap acidosis, most likely you are dealing with HMG-CoA lyase deficiency or ketogenesis defect. If the ketose is present, check the ammonia level is high or low or normal. If the ammonia level is high, most likely you are dealing with methylmalonic acidemia or propionic acidemia. If there is no ammonemia, most likely maple syrup urine disease, methylcrotonoglycinuria, glutaric aciduria, isovaleric acidemia, or multiple carboxylase deficiency. So this is the way you analyze metabolic acidosis, especially in newborn. Most often, these patients present during newborn or infantile stage. So when you have a lactic acidosis, do the lactate pyruvate ratio. If there is an increased lactate, look at the tissue perfusion. It's the most common. When you have a tissue perfusion is affected, resuscitate and treat. It could be because of fluid loss, hemorrhage, sepsis, or cardiogenic. So all these resuscitate and treat. When there is no hypoperfusion, but there is a lactic acidosis, possibly you are dealing with mitochondrial electron transport chain defect, and refer to the people who deal with metabolic disorder at that point, which is a little bit more advanced at that point. Most of the centers do not even know how to evaluate mitochondrial electron transport chain defect anyway. On the other hand, lactic acidosis, but the lactate pyruvate ratio is more than 20. Give, well, there is no predominant lactate. Then response to feeding or IV glucose. When the lactate increases, pyruvate dehydrogenase complex deficiency. Even though it looks very uncommon, but I do have a pyruvate dehydrogenase complex deficiency child. I am seeing here. Um, when, prior to that, I never seen. On the other hand, when the lactate decreases, there are two possibilities. Pyruvate carboxylase deficiency as phosphoenol pyruvate carboxykinase deficiency. This is how you evaluate lactic acidosis in newborn and infants. Now, all those patients present with inborn errors of metabolism always check glucose, make sure there is no hypoglycemia, electrolyte disturbances, LFTs, lactate, ammonias, and serum or urine ketones. And take a sample. You may not be available at your center. Take a sample, send for plasma amino acid, plasma carnitine and acyl carnitine analysis, urine organic acid, and urine fluorescein glycines. So how do you treat? When the patient presents with suspected inborn errors of metabolism causing acidosis with intracranial illness, sometimes it may not manifest just like that. Respiratory other illness will make it visible or make it happen at that point. So when there is a acidosis of unknown origin, number one, fluid resuscitation, correct hypoglycemia. If they're present with hypoglycemia, stop natural protein. If the child is feeding, stop that one. Don't feed if the patient is enterally fed. Continue safe amino acid formula. I would say when they present acidosis, I will stop all protein needs. Consider IV carnitine, and if the patient is improved, adequate, continue initial resuscitation. If the patient is sick, inadequate, most of the time they are. What you need to do is discontinue natural protein for 48 hours. It takes time for it to convert back, and provide calories by giving D10 or D12.5 plus intralipid emulsion, 20% fat emulsion. And after 48 hours, I'll start with amino acid formula and slowly go up. That's how we do it. Number one, you need to break the cycle, then introduce amino acid formula. If the acidosis is very severe, you need to treat with IV bicarbonate. When there is hyperglycemia, treat with IV insulin, especially when the sugars are more than 200. And antipyretic therapy is also important. The increased temperature can cause muscle breakdown that can cause gluconeogenesis and hyperglycemia. So keep that in mind. And these patients will have nausea and vomiting because of acidosis. So that needs to be taken care of. And make sure we are not missing the diagnosis of pancreatitis. So these need to be typical patient when they are that sick. Keep them NPO, D10 or D12.5, follow the sugar, follow the acidosis. If it's severe, treat with the bicarbonate. Most of the time, it works. After 24 to 48 hours, reintroduce the amino acid formulation. The patient has hyperammonemia. Ammonia levels are high. Again, same. NPO, IV glucose. Consider sodium benzoate, phenyl butyrate, 250 milligram per kg per day, and the arginine infusion. If the ammonia is high to start with or non-responsive for the ammonemia and acidosis, and next is hemodialysis, especially when it goes 300, 400 ammonia level or severe acidosis, not responding to all these maneuvers, they need to go to hemodialysis. But this is the way you approach. Number one, keep them NPO, D10, D15, and correct the acidosis and check ammonemia and go from there. This concludes, the key considerations in acidosis: avoid overcorrection. because it can cause hypokalemia, hypercalcemia, and metabolic alkalosis. And the monitor response, frequent blood gases, electrolyte, and hemodynamic monitoring. And that was the complications if it happens. Most of the time, it doesn't if you are aggressive enough. Treat arrhythmias, hypotension, and organ dysfunction promptly. This concludes seminar on metabolic acidosis.